My name is Naval Davar. I am an associate professor in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. Today I will be speaking about Flit3 inhibitors in acute myeloid leukemia, specifically midostaurin that was recently approved in combination with induction chemotherapy for frontline treatment in patients with acute myeloid leukemia. Over the last 14 years, there has been a significant development in the field of acute myeloid leukemia with a number of targeted therapies. Most prominent among them are the Flit3 inhibitors. At MD Anderson, we have been using Flit3 inhibitors now for the last 14 years. In this slide, you can see that as compared to the survival of Flit3 mutated AML in 2003 to 2005, there has been a dramatic improvement in the long-term survival of these patients in the most recent analysis that we did in 2011 to 2013. This is predominantly due to the use of Flit3 inhibitors as well as allogeneic stem cell transplant in Flit3 mutated patients who inherently have a higher risk of disease relapse, progression, and inferior survival. The Flit3 inhibitors we have been using were initially first-generation agents such as sorafenib, midostaurin, lestartanib, and more recently quizartinib, gilteritinib. I think the appropriate use of these Flit3 inhibitors in combination with either high-dose chemotherapy or hypomethylating agents, as well as increased awareness that Flit3 is an adverse prognostic factor that should be checked up front in all patients, and the use of stem cell transplant as an early intervention in these patients once they achieve remission are predominantly responsible for the improvements in the survival. Today we can say that if we identify a Flit3 mutation up front, treat these patients with a Flit3 inhibitor in combination with induction chemotherapy, and take them to allogeneic stem cell transplant with available donor, we are able to achieve 5-year survival rates of 65% or greater. Flit3 inhibitors in current development. As you can see from this slide, a number of Flit3 inhibitors entered phase 1, phase 2 trials, and a few of these have gone into phase 3 trials. The most important among these lists at this time from the clinical standpoint are midostaurin, which has recently been approved, and we will talk more about the Ratification Study that led to the approval of midostaurin in the frontline setting in combination with induction chemotherapy in Flit3 mutated AML. In addition, the other Flit3 inhibitors that are either in phase 3 studies or have recently completed their phase 3 studies include quizartinib, which actually completed the phase 3 study in the salvage AML of quizartinib versus standard chemo, and we are waiting for the results, as well as gilteritinib, which is being evaluated in 3 phase 3 studies, and crenolinib, which is also being evaluated in phase 3 studies. The advantages of gilteritinib and crenolinib seem to be that they have activity not only against the Flit3 ITD, but also against the Flit3 D835. This has been shown best with crenolinib, but there is some early evidence that this may be true for gilteritinib as well. Now we will discuss the Ratification Study, which was a phase 3 randomized study for newly diagnosed patients with acute myeloid leukemia who were candidates for induction chemotherapy. Patients were randomized in this study to receive either midostaurin plus chemotherapy or placebo plus chemotherapy. Of note, patients only who had a Flit3 mutation were eligible for this study, but the patients could have either the more common Flit3 ITD or the Flit3 D835 mutation, as midostaurin does have activity against both forms of the mutant. About 3,500 patients were screened to identify 700 patients with Flit3 mutations. This is as expected, as the incidence of Flit3 in the general population is somewhere between 20 to 30%. Patients then got induction with standard chemotherapy, specifically daunorubicin plus cytarabine, in a 3+7 fashion, and then they would get midostaurin added on from days 8 through 21 of the induction, as well as 3 to 4 subsequent consolidations, or would get placebo during the same time frames. The primary endpoint was overall survival. Of note, the consolidations in this study were similar to the consolidations that are traditionally used in 3+7 induction and included cytarabine at 3 grams per meter square, given twice a day on days 1, 3, and 5. And again, as noted, the midostaurin was given on days 8 through 21 of each consolidation as tolerated. After completing 3 to 4 consolidations, the patients could get maintenance with midostaurin for up to 12 cycles, and this was included as part of the study design. Here we see the overall response rates. As we noted before, a total of 717 patients randomized, with 360 who received midostaurin and 357 who received placebo. The response rates were slightly higher in the patients who received the midostaurin plus chemo, but did not achieve statistical significance. When all the responses were aggregated, including the best response achieved at any time on study, there was a slight more pronounced improvement in responses in patients who got the midostaurin-based combination with the statistical significance achieved, and this data will be updated at the ASH meeting this year. However, the key endpoint of this study was median overall survival. As you can see, there was a significant improvement in median overall survival, as well as an improvement in the 5-year survival, and this remained significant even after censoring for stem cell transplant, indicating the benefit of the tyrosine kinase inhibitor midostaurin when added to induction in FLT3 mutated AML. Here you see the survival curves. What we note is that there is a clear separation of the curves from the beginning, and this is maintained at 5 years and beyond. Overall, there was about a 23% relative reduction in risk of death at 5 years in patients who received the midostaurin plus induction chemotherapy. This was statistically significant, but in my opinion is also clinically significant, as it does show that there is a significant chance of having a better survival at 5 years and beyond if midostaurin was added to induction chemotherapy in FLT3 mutated patients. In general practice, I think that this should translate into all patients being checked for the presence of a FLT3 mutation at baseline. And if they do have a FLT3 ITD or D835, they should have midostaurin added to the induction on days 8 through 21, as well as midostaurin added to consolidation and maintenance, as was done in the Ratification Study. Again, the treatment does apply for both ITD and D835, and the benefit was seen in patients with both forms of FLT3 mutation. One of the concerns we have when we add novel therapies, whether they be tyrosine kinase inhibitors, checkpoint inhibitors, or monoclonal antibodies to standard induction in AML, is that there may be added myelosuppression or associated toxicities that may negate the possible benefits. What you see in this study and on this table that has been taken from the published study in the New England Journal of Medicine by first author Dr. Stone is that the patients who received midostaurin with induction, as opposed to those who received placebo with induction, did not have a very significant signal for increased myelosuppression or neutropenia-associated infections. Of note, there was a slight increase in rash and skin change, which are known side effects of midostaurin, but in most cases these were manageable, and very few or no patients came off study due to this toxicity. Interestingly, nausea was higher in the placebo group. We do not know the reason for this. When looking at the aggregate toxicity profiles, what we notice is that the addition of midostaurin to the induction chemotherapy, especially when it was given on days 8 through 21, was generally well tolerated without a strong signal for increased toxicity, myelosuppression, complications, basically indicating that this regimen can be administered in general practice with improvement in survival of the patients and should be standard of care. Thank you very much for listening to this review.